when you sort of add all this up and what we spend as a country in terms of our gross domestic product, and we're almost spending $1 out of every $5 on healthcare. So it takes a big chunk of our economy in this country. So healthcare policy is incredibly important that we get good value for that investment we're all making.
Hey y'all, this is Kosta, and today I'm here with my guest, Dr. David Grabowski, professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. Dr. Grabowski is a member of the Medicare Payment Advisory Commission, an independent agency established to advise the U.S. Congress on issues affecting the Medicare program. Throughout his tenure, Dr. Grabowski's research has been supported by the National Institute of Aging, the Agency for Healthcare Research and Quality, and the Centers for Medicare and Medicaid Services. Today, we're talking about healthcare policy and why you should care. Welcome, Dr. Grabowski. To start off, would you give us a brief overview of your background and what led you to focus on healthcare policy, specifically in the area of long-term care and aging?
Sure. So first, thanks for having me on today as a guest. I'm delighted to be here. So I got interested in healthcare policy, oddly enough, through my family. My dad is an economist. My mom is a registered nurse. So my interest in health policy is almost the perfect overlap of their careers. And I very early was hearing about health policy issues. Unlike a lot of my friends and colleagues, I wasn't interested per se in becoming a clinician of any type, deliverer of healthcare services. I was really interested in kind of how it all worked in terms of healthcare policy. So that's what first got me interested in this area. I was an undergraduate major in public policy, interested in the health area, was doing a independent study as a senior, and my advisor at the time suggested I write on long-term care. Like most college seniors, I had no idea what he was talking about. I just kind of nodded my head, went back to my dorm room, kind of, what is this long-term care thing? I started reading on it. I ultimately did write my independent study paper on long-term care, and I've never looked back. It was everything that interested me about healthcare policy was here, only more so in long-term care. The role of government, the role of incentives, the role of substitution between family and formal services. Just it was all here, and it was all super interesting to me. And I spent a year working in Washington, D.C., went and got my PhD at the University of Chicago. And then throughout my career, I've dabbled in some other areas, but my heavy foot in research has always been on issues around long-term care and aging.
Can I ask, since you started to where we are now, what do you think's changed the most in long-term care?
It's changed tremendously. So I think when I first got in this field, even 25, 30 years ago, it was very nursing home or institution focused. That's where the money was. That's where the people were. That's where a lot of the research and all the attention was there. And if you ask anybody about long-term care, that's not really where they want to receive services. I'm not saying we should eliminate nursing homes. I think we're always going to have them. Hopefully we can have better nursing homes. I'm sure we'll talk more about that issue as we
sure will.
But I think we were so nursing home dominant or focused. And what's really changed over the last 3 decades has been this transition out of the nursing home and towards the home and the community with more services. So 30 years ago, it was a nursing home or family and loved ones providing care in the home. Today, there are a lot more paid services in the home, and then there's a lot more steps between home and the nursing home, whether it's a board and care home, whether it's assisted living. There's just a lot more options. I think the menu has really broadened out from home from family and nursing home to a lot more options. And I think that's great. That doesn't mean we don't have a long way to go in terms of improving quality, access to services, who pays for this. There are a lot of issues, but we've come a long way, and we have a long way to go in terms of long-term care policy.
Could you simplify healthcare policy more broadly? And why it's important for us to understand it?
Yeah, so I would define sort of long-term care, healthcare policy broadly is kind of the financing, the payment, the organization and delivery of medical and social services for individuals in our system. And we have a healthcare policy model in this country. Other countries have different models. All of them kind of have a reliance on public and privately delivered and paid for services. We have healthcare policies at the federal level, of course, and in terms of long-term care and aging, there's a lot of important federal policy, but state policies are also incredibly important in this area in terms of Medicaid. Medicaid is the dominant public payer of long-term care services in this country. And then at the area or local level, we have policies as well that are quite important. So healthcare policy, it's incredibly important because it ultimately matters for the quality of care that we receive. And what I mean by that is how we pay, how we deliver, how we organize services ultimately impacts our quality of care. It's going to impact our access to services. It's going to impact what we all spend on services, both out of pocket, but also as a country in terms of our tax dollars. So when you sort of add all this up and what we spend as a country in terms of our gross domestic product, and we're almost spending $1 out of every $5 on healthcare. So it takes a big chunk of our economy in this country. So healthcare policy is incredibly important that we get good value for that investment
Absolutely.
We're all making.
Well, and also if you consider the statistics, 1 in 4 Americans is receiving Medicaid. So that means that's roughly about 80 million Americans who are currently on some type of government-sponsored insurance. I mean, I know we're talking about long-term care and not all of those people that are on Medicaid qualify, but I think we forget just how much healthcare touches our lives. And we were talking about this a little bit earlier before we started the show. I mean, in smaller towns and rural cities all across the United States, healthcare sometimes makes up 50%, if not more, of the entire available jobs. And how can we corral a system to work better for Americans with it being the size that it is? I mean, it's like a behemoth.
It's a huge behemoth, and unfortunately, it's a very fragmented behemoth.
Right.
And you use the word system, and I use that as well to describe it. But is it a system when you have all these sort of silos? And
it's like a moving target.
It really is. And think about just the care of older adults. So that's just a small part, an important part because they spend a lot on health and long-term care services, but just to give your listeners a kind of a window into this group. So as you suggested, Medicaid is paying for their long-term care services. So their nursing home care, their home and community-based care, depending on the setting. Then Medicare is paying for all of their health care. If they need to go to the hospital, their physician care, their short stay care in a nursing home, that kind of post-acute rehabilitative care, that's Medicare. Hospice would be Medicare. All their drug spending would be Medicare. And so trying to put those two very different benefits together, and this is just two benefits for one group of individuals, has proven to be very challenging for our country. This happens every day for all of us, and you're trying to put together all these different payers, all these different providers of care across the spectrum, from long-term care to acute care, and it's incredibly complicated. Behemoth is a good word. I wish it was more of a system. I call it that as well, but I wish it was more of a coordinated system because I think we could get much better care if it was, but unfortunately it's quite fragmented.
Are there any countries that you're aware of that have a healthcare system similar to the United States?
No, we are.
I don't think so either.
We're an outlier, and not in a good way. And that we spend a lot more than these other countries. There are certain things, and I'm not trying to put down any of the providers or clinicians or people in our system. We have amazing places and people in our system. We do some things very well, but as a whole, like we spend so much more, and we don't look so good relative to a lot of other countries in terms of outcomes.
And I know that we're getting a little bit off topic, so we're going to go right back to the questions here in a second. But before I do, I think it's almost in our nature, though, Like, I think the way that we've been programmed from a very young age, we've incorporated some capitalistic ideology into all of our decision making. And so just because it costs more money doesn't necessarily appeal as a negative to us. It may even do the opposite, because we value things that are more expensive because we think it provides higher value or better quality. The interesting pivot. Go ahead, Mel.
No, I was going to respond to that and say I totally agree that it's really about our values, and we value these services and being able to get that cancer care, whatever it may be, those high priced drugs. It's really important to us. You asked earlier about healthcare policy. There are people like me that study healthcare policy in countries all over the world, and when I meet with colleagues who study healthcare policy in Europe, they often use this term solidarity, and that we're all in it together. And if I get very expensive cancer care, does that, what does that do to the budget? And, or in terms of long-term care, should we all kind of pay into this system such that, there's something for everybody here versus the more capitalistic. So it's finding that balance. We are who we are, and there's a lot of great things about our system, but it's these kinds of trade-offs. You never hear the term solidarity in our system, and we have when you think about long-term care, we have a system that's public-private, and it's very much based on, I'll fund my long-term care, and your family will fund yours, and on and on and on.
Yeah. Let's talk about your work with the U.S. Congress. Yeah. As a member of the Medicare Payment Advisory Commission, you advise the U.S. Congress on issues affecting the Medicare program. What are some of the most pressing issues that MedPAC is addressing right now, and how might these issues impact our everyday lives?
Yeah, great question. So MedPAC... So first of all, we're a 17-body commission. We advise, as you said, the U.S. Congress on different issues, some of which we identify, but many of which the members identify and come to us with questions. We've done reports recently on telemedicine, on the safety net. You name the part of the Medicare program, we've looked very, very closely at it. And I think the issues, I'll highlight three and try to tie them to how they affect our day-to-day lives. The first is that MedPAC has been very concerned about what is the right sort of payment rate for these different sectors. So MedPAC is congressionally mandated every year to make a payment recommendation to the Congress about what should hospitals be paid, and what should physicians be paid, and skilled nursing facilities and hospice, and on and on and on. And trying to figure out the right kind of rate has been something that the commission has long had an interest in doing, but I think it's never been more important, given we all know some of the looming budgetary issues here with the Medicare program and how we're going to fund this in the years to come. And so,
very timely conversation.
Oh, absolutely. And how do you think about what's the right rate to be paying to these different providers? Understanding that each of these dollars is somebody's job, and you mentioned earlier labor and these workforce issues, and trying to figure out what's the appropriate rate. So that's been a huge area of focus. The second has really been the growth in Medicare Advantage. And quickly for your listeners, I know this is a very sophisticated group, but there's two types of Medicare. One is traditional fee for service, and that each of the different services are paid kind of separately a payment rate. The managed care version of Medicare is called Medicare Advantage. And when I first got on the commission 6 years ago on MedPAC, about a third of Medicare beneficiaries were on Medicare Advantage. Today, it's just under 50%. So this is
incredible,
growing like gangbusters. Yeah. And where's it going to be in another 6 years? It's soon going to be more than 50% of the program. And so MedPAC's been very interested in kind of what are we paying these different plans? This is privatized. Are we getting good value for that investment? How do we incentivize good quality competition? All of the issues you'd want to think about in the fee-for-service space. But I think historically, when most of our beneficiaries were in traditional Medicare, I think Medicare Advantage was kind of not on the back burner, but it wasn't front and center. Guess what? Right. Going forward, that's going to be front and center. Yeah. And then the final issue that I want to touch on quickly, that I think is really important in everyday lives, is how do we get good value, given there still are a lot of beneficiaries in fee for service and Medicare Advantage? How do we make sure that even though we're paying kind of a perspective, a fixed, a predetermined rate, how do we make certain that there's good quality that's happening? And there's been a lot of advances over the last 5 to 10 years in these alternative payment models, like accountable care organizations and all these like buzzwords. I don't want to give all the acronyms because I think people's heads will start to spin. But
I know.
But that said, this is the future, and this is where the healthcare system is going. And how can Medicare help make certain that beneficiaries are getting really, good quality care here, and that we're actually lowering spending for all of us?
I have follow-up questions to each one. And so anybody that's watching this or listening to this, just hold on, because this is about to get really technical.
Oh, no.
So with regards to affordability, okay, the latest statistic says that most retirees, they typically retire with a little over $200,000 in total money. So that's not a year or a month or anything like that. That's literally their entire savings. They get Social Security. How can people afford to access these services like long-term care if they don't qualify for Medicaid and they only have $200,000 to spend? Why do we have policy that essentially says you'll spend all your money and then we'll put you on Medicaid? Like, why?
Yeah, it sort of comes from this idea that a private market will develop, but as you're suggesting, the private market has really targeted a much wealthier group of individuals.
Right.
We wrote this paper several years ago before the pandemic called The Forgotten Middle. And it's exactly the group you're describing. They have some savings, so they're basically too wealthy for Medicaid, yet not wealthy enough to buy into a very expensive senior housing or senior living community. They're sort of stuck in the middle. And we've expected that, they'll buy into maybe private long-term care insurance. That market has never taken off. Most people haven't. And so ultimately they do exactly what you suggest. They end up spending down their assets and qualifying for Medicaid. And that really wasn't how we intended that program to work, but it's really become the safety net. And it's much more individuals who were kind of middle income their entire lives end up using Medicaid to pay for their long-term care services exactly for this reason, because there hasn't been enough in the system, enough options in the system. And so one of the things that I've advocated for is we there are other countries that approach the financing of long-term care very differently and have, much like we have Medicare, this comprehensive medical coverage. Why don't we have comprehensive long-term care coverage that would cover, all of these services, and kind of, we could pay into these kinds of models over our life course and then have this, much like the Netherlands or Switzerland, mainly Northern European countries that have really figured this issue out.
Well, and Washington is, they're
Absolutely
working with that. And we talked to the director of the Washington Cares Fund, and it's fascinating what they've been able to accomplish in a short period of time. Also maybe even, and I've said this on previous shows, maybe even making long-term care insurance like auto insurance. It's just a requirement that you have to have. That's also an option. So the other follow-up question, I'll just leave it at 2 because we'd be here all day if I keep going. The other follow-up question is, and I want to, this is more of like a theoretical hypothesis, more or less, for you. I don't think that we will ever have the political feasibility to pass a single payer system at the federal level. So let's just go ahead, and anybody watching this, y'all can just stop thinking about that, because that's probably never going to happen. However, as Medicare Advantage grows in popularity, these insurance companies that are offering these plans they have a higher and higher overall gross revenue coming from federal and state governments. Businesses merge, businesses, consolidate, industries become smaller. Do you think that there is a possible future for a consolidation of the industry to reach a single payer system that is directly in partnership with the federal government. So it's kind of like a workaround policy to get to a single payer system where the federal government is talking directly to one entity. The entity controls, not controls, but the entity is responsible for all the individuals on Medicare and Medicaid. And the federal government dictates all of the finances, essentially.
Yeah, I don't see us having just one company, and I think that kind of consolidation, I think we really resist for lots of reasons. Maybe giving too much bargaining power to this other entity. Although, as you're suggesting, if you had the federal government and the state government saying, "Here's what we're willing to pay," both sides have a lot of power in that negotiation. You would think,
sure.
But I do like where you're going with this. That eventually, if lots of our beneficiaries are in managed care on sort of both sides, on both the Medicare and the Medicaid side, and it's the same company, can we think about coordinating? Can we think about really being very uniform in terms of benefits? And all of a sudden, maybe it's not just a single payer system, but it is a much more coordinated, uniform system. You can almost think maybe Medigap isn't the best example, but here's the kinds of policies you have to offer. Here's what's covered. Here's what you can charge. That kind of model. I think we could sort of be a lot more forceful in terms of dictating what these policies look like. And to your point, maybe it's one big company, but do we care if it's 10 companies as long as they're offering this kind of, above this level? And I think we'll have the right chassis to build those models as more and more of our beneficiaries go over to managed care.
It's kind of like a healthcare exchange.
Absolutely.
So like healthcare.gov, regionally, there's specific insurance companies in each individual region. And then there's big insurance companies that cover the entire United States. Right. And so maybe I guess what I'm trying to say is the foundation has been laid very slowly.
Yes.
Very slowly.
We're headed in the right direction. You're exactly right. It's just progress is slow, but we're slowly getting there.
Very true. So on that note, though, can we talk about how healthcare policy has evolved to address the growing demand for long-term care services, and also what improvements can still be made?
Yeah, so going back, I think to my earlier answer, it's healthcare policy with respect to long-term care. I do think we've seen this huge evolution away from the institution, and I think today, many states now in Medicaid are paying a lot more for home and community-based care. Unfortunately, a lot of states have huge waiting lists for those services. It turns out they're very popular. Guess why they're popular? That's what people want. And I one of my lines is that I've been doing this a long time. I've never met the person that wants to go to a nursing home. That said, I've met a lot of people that want care in their home or in the community. And so how do we continue to expand those services? And I think there have been really positive steps in that direction. Assisted living, how do we make that more affordable? Right now, it's very much a private pay market. How can we get more sort of Medicaid coverage of those services? That's what our beneficiaries want. I once again, I don't, and I think the pandemic has really driven this point home. I think this shift out of the nursing home into the community has been a really powerful one. Ultimately, we need to transform nursing homes too, but as we're shifting individuals out, let's give them the options and let's help them pay for them. And I think you said it perfectly earlier. Most of our retirees don't have a lot of resources. If anything, they're house rich and kind of cash poor. And, once they sell their house, then that's all they have to kind of live on. And so we have to find options for them that work.
We talked about how fragmented the system is. Sometimes when I'm trying to go to sleep at night and I'm pondering, I think to myself, are we making it even more complicated? And the reason that I bring that up is because in an institution, in the facility-based care setting, right? So in an institution, you're a vessel and you are essentially moving people into that environment. to create efficiencies in any market, you need to have some streamlined, processes, something that you consistently, rinse and repeat, something that you can follow. When you incorporate community-based care, which is what I do, so I'm very familiar with it, every single environment is different. Every single training is different. There is no set handbook. And it's very hard to scale and build capacity with so many variables. Do you guys ever talk about that in your policy?
We absolutely do. And I, for better or for worse, like as you said, nobody wants to be in a nursing home yet. Once you're there, the services can all come to you. And for whatever reason, you are the hub. The nursing home is a hub. There are economies. You're not reinventing the wheel. A lot of the more innovative care models happen at the nursing home level just because you have this concentration of individuals. Right. And once you move to the community, you lack all of that. We wrote a piece and convened some thought leaders around this issue recently. We were really perplexed just around, and exactly the point you're raising around navigation. Like everybody has to figure this out for themselves. Are there resources for how do I find that home care aide? How do I coordinate that person with my medical services? And what happens if my health declines and I need to transition? What are my next options? And we called the long-term care system, the title of this piece, we published it in The Hill. We called it A Road to Nowhere. And it's because it's like, it's just, there's not that, there's nowhere to go here and there's no one guiding you along this road. And it's really, it's really sad that that we haven't figured out kind of that coordination function. We have, as you know, some resources like what we call the AAAs, the area agencies on aging. Some are quite good. Some are lower resourced, but they don't always meet all the needs in terms of sort of coordinating and navigating the system. There's a lot of private services that are out there. Some are better than others, but I'm a little wary of places that accept payment to direct you to certain communities. So I would ask your listeners just to be wary of kind of what's out there. But I do think the AAAs are a good first place on this. But we have a long way to go in terms of figuring out the navigation.
And so in Tennessee, just for anybody that's watching that's in Tennessee, there's development districts and the AAADs, the Area Agency for Aging and Disabilities, is housed under those development districts, and there's one in each region of Tennessee. I wanted to ask you one more question before we moved on to quality of care, specifically in facilities. When I talk to TennCare, we talk about training for DSPs, direct support professionals, and caregivers. As they're describing what a training model should look like, I immediately start to think like, wait a minute, this is like a book of human psychology. So if I needed to understand the psyche of an individual, the training manual would be this thick, because it's not as simple as learning, the typical non-medical home health care tasks of, grooming and bathing and errands and cooking and cleaning. Like, it's not just those things. But here's a point. And I told you we're going to get a little technical in this episode, so bear with me. One of the biggest issues in where I live in Cookeville, Tennessee, and I'm assuming that this probably affects a majority of the United States, is a lot of people don't have what's called soft skills in employment. They don't know essentially how to work. And I wonder, given that community-based care requires people to have that proficiency, they have to have soft skills. Like, that's their number one requirement, is soft skills. How do we affect the problem of not having enough caregivers because we don't have enough qualified people to care for all the people that are aging? Yeah,
this is the number one issue I hear, like when I talk to providers, policymakers, everybody today. It's where are we going to get the caregivers? And I think there's probably several different ways. One, and I'm a health economist, so you can probably guess my first thing I'm going to say here is it's about wages, and we just have to pay this workforce better. We lost a lot of workers during the pandemic to Walmart and Amazon and lots of other employers. And once again, who's working in a nursing home or a home care agency? Yes, there are RNs and LPNs, and they are likely going to other healthcare jobs, but there's a lot of certified nurse aides or home care aides. They bounce between healthcare and non-healthcare jobs. And so making this a job worth having. So that the first is wages. The second, and I think it goes to your point about sort of softer skills, we need to sort of give them training and also empower them and give them autonomy once there. This is more of an issue, I think, in the institutional settings where there's a real hierarchy in how we set up our workforces, and CNAs, it's a challenging job to begin with. You're, as you said, bathing and dressing and grooming and doing all of those tasks.
Very tough.
With residents who often have high levels of dementia. It's super challenging, super rewarding work, but super challenging. I think part of this is that we don't always treat our staff very well. The culture in a lot of nursing homes that I've been in around the country aren't great. There are some counterexamples of places where we do really empower this workforce and give them autonomy and give them voice in this job, but all too often we don't. And so, yes, let's give them a set of skills, but let's also let them use those skills once they're in these jobs. And
you're right.
That sounds very simple or trite. And this is where policy meets kind of management and delivery of services. On the policy side, we can mandate or at least try to encourage better wages for workers. That's a policy instrument. Changing the culture in the buildings, is that healthcare policy? There's management in there? No, it's not. And so like I think higher wages are necessary, but they're not sufficient. We're not going to get workers alone. One of the very quickly, a research study that came out across all healthcare jobs, nursing home workers actually experience the largest relative increase in wages across all, more so than physician offices, hospitals, home health, any of the other jobs during the pandemic. Yet we lost the most workers in this sector. And it's really about the idea that the culture, this is really challenging work and got much more challenging during the pandemic. And so, yes, we need higher wages, but we probably even need higher than we've increased them to date, plus a change in the culture.
And I think a lot of it also is the fact that when we talk about nursing homes, we always start with skilled rehab because that's what Medicare pays. And then we start talking about private pay patients that pay out of pocket. And then we kind of kick the can around and say, oh, and then there's those Medicaid patients we got to keep all those beds open for. I mean, if you could change the narrative, you might be able to start changing the culture. But there's a common thread between all three categories, and that's your reimbursement rates. And so at some point, you got to, call a spade a spade. And I'm not here to talk about provider rates and advocacy or anything like that. I'm just saying sometimes the problem is just so simple that if we just were willing to accept it for what it is and say, well, I guess, makes sense. Let's see if this works. Then we might actually have pretty positive systemic change quickly.
This was far and away my greatest frustration from the time I've been on MedPAC. Medicare, so very quickly for the audience, Medicare pays for a relatively small share of nursing home days. That's post-acute rehab following a hospitalization. So basically, 4 weeks, 5 weeks, up to 100 days, but very few of our beneficiaries get out to 100. It's really on average about a month of rehab, but huge margins on that care for providers. They're making nursing homes do really well on those short stay patients. The vast majority, however, of their bed days are, as was just suggested, long stayers. These individuals who, some are private, but the vast majority our Medicaid. Medicaid is a loser in most states.
Yeah.
And so you have this really odd setup in nursing homes where a very small number of post-acute rehab patients are from one government payer, Medicare, are cross-subsidizing this other government payer. So on MedPAC, going back to my earlier comment, we would be recommending cuts for skilled nursing facilities in the Medicare rate because it was so generous, even though a lot of nursing homes during the pandemic were, struggling. And so how do you sort of, kind of come to grips with these two ideas that, on MedPAC, we were very focused on Medicare policy. That's what's in the name. That's what our job was for the Congress. And so from a Medicare perspective, we're overpaying nursing homes. Right. From an overall healthcare policy perspective, however, you said it well. We need to make sure that we're paying a rate that's commensurate with good quality care, and many state Medicaid programs just aren't. That's not to say there aren't other issues in nursing homes, but that's an important one, and we should make sure we're paying them a fair rate, and then that those dollars are going into direct resident care.
Let's talk about quality of care. Yeah. In your opinion, what are the key indicators of quality in facility-based care, so essentially nursing homes, and what can potential residents and their families do to ensure they're choosing a facility that provides high-quality care?
Yeah. So my number one, and it would be 1, 2, 3, staff. Like, it's really, nursing home care is about staff. It's not highly technical in most instances. It's about delivery of assisting these residents with activities of daily living. Like we've been talking about bathing and dressing and toileting. That's about having enough staff there to meet the resident needs and ensure they get good quality care, but also have a good quality of life. If they want to eat something, if they want to, whatever they want to do, they need help with things you and I do every day and are, take for granted. They need assistance with. And so you don't have the staff there, and not just the numbers, but the experience. And so I would encourage anyone that's looking at a nursing home, the first stop, go to Care Compare on the Medicare.gov website. Go into the nursing home compare part of the web and check out the staffing, both the levels, but also the turnover in these buildings to make sure, one, the turnover isn't too high, but then the levels are sufficient. And that would kind of be my first stop. That wouldn't be my last stop. It would be one of my first to make sure. And then I think on top of that, going into the building, and not just when the admission director takes you around, but also at some other time, maybe unannounced, maybe on a weekend, maybe in an evening, and really kind of get a sense of the building, talk to some of the residents or their families, talk to some of the staff. Like I love to talk to staff when the admissions director, the leadership isn't around. You can learn a lot. And in the best nursing homes, no one should be nervous about me talking to anybody. If you're running a good quality facility, you don't care if I'm talking to your staff, and I wouldn't care if you were talking to my, that should go without saying.
You should talk to like 2 or 3 CNAs on each floor or each wing. And you'll know all you need to know about, whether this nursing home is doing a good job or not. Because I'll tell you, obviously we employ a lot of caregivers, DSPs, aides, and they are solid when it comes to telling the truth. They really do understand what's happening on the ground. And you don't get any salesmanship from those positions. They are very much going to tell you how it is. No, one of my colleagues likes to say, when you go into a nursing home or assisted living, beware of the glass chandelier effect. Like you said, ignore the chandelier, talk to the staff. The staff will give you the real story. Yeah. Just walk all the way to the back. That's right. There's nothing about the facade up front or the nice paintings or the rug up front. All of that. Do not fall for that. Staff will give you the real story. Let's talk about the pandemic. Yeah. So the pandemic has had a significant impact on long-term care facilities. As a member of the CMS Nursing Home Coronavirus Commission, can you share some lessons learned from that experience and how those lessons could help improve long-term care facilities moving forward? Sure. So I was part of this CMS, 25 of us, part of the CMS Coronavirus Commission with the idea of giving back. This was back in 2000, giving
kind of nursing homes and policymakers a roadmap out of the pandemic. And our recommendations were very much about supporting nursing homes. They needed a lot more resources at that point. And the research was really clear. The pandemic hit nursing homes based on the spread in the local area. So if COVID was in the community around a nursing home, it was highly likely it was coming into that building. And so that suggested we needed to support nursing homes across the board with more personal protective equipment, more testing, just more resources to really help training, to help staff, benefits and pay, hazard pay for staff. These were the kinds of measures that were really important. Yes, there were some bad apples in places that didn't handle the pandemic, and we read about those and saw those places on television. But in the vast majority of instances, it was about where you were, not who you were. And, it wasn't about being a high Medicaid facility. It wasn't about a facility with a history of, deficiency violations or anything like that. I also think, in terms of other lessons, we really learned, what didn't work, trying to ask nursing homes to get their own personal, protective equipment, PPE, or get their own testing. That didn't work well. What worked well was when we centralized these approaches. And I'll point to a success story where the vaccine clinics that the federal government ran, where they actually went in and set those up for, came into each nursing home and assisted living facility in the country 3 times. We got a lot of our residents vaccinated, and we've really seen the benefits of that vaccination effort. And that was very centralized. We had pharmacies that did that, and there were a couple of states that did their own thing, but most were in the federal model, and that was highly successful. I wish we had been more centralized with all of our with all of our sort of COVID policies in regards to nursing homes. The final lesson, and this one kind of caught me off guard, but it makes total sense, was that, we saw COVID spread. Yes, it was about the local area, but the way it spread in the local area was about the staff coming in and out. And, they were asymptomatic. I'm not blaming any staff. They didn't know. They had to work. But they were going home to a community. If it was all around their community back in 2020 and 2021, it was going to be in the nursing home. And it turned out nursing homes that were smaller with fewer kind of staff going in and out did better. And we have these huge nursing homes in this country. And many times the staff were working across buildings and working across different nursing homes. And we found, other researchers found that actually helped spread the COVID from one nursing home to another, having more staff in and out. So smaller nursing homes with kind of staff that are directly responsible for that nursing home, less use of contract nurses. These things could have helped during the pandemic.
2 things. And then we have a few more questions, and then we're going to wrap up. Sometimes I feel like in long-term care, I've been doing this for about a decade now. So aside from, I had a job for 5 years at a Land Rover dealership when I was 19. So I did that first. And then we started working in this industry, and then we ended up buying this company in 2015. So my wife and I have owned it since then. I've seen a lot. It's changed dynamically over the last 7-8 years. Sometimes I feel like it's somewhat of a blind leading the blind, and let me tell you why. So, and when I say blind leading the blind, I mean state agent, state Medicaid, and wherever the policies that they're getting, wherever they're coming from, to decipher back to the provider, down to the provider level. It just seems like, where did they come up with this, and who's talking to who about, implementation? When the pandemic happened, April of 2020, at the end of the month, I'll never forget it. We're sitting there with myself and my COO, and we're sort of trying to game out exactly what's going to happen. No idea what's going to happen. But we know that one way to prevent the spread of COVID-19 was to reduce staff entering and exiting our residential homes. And we have about 40 residential homes with 3 individuals in each home. And we usually have staff turnover every, shift change every 8 to 12 hours. So I said, I've got a great idea. What about we create a live-in caregiver environment for 2 weeks on, 2 weeks off, and we'll change them out every 2 weeks. Now, it wasn't ironclad, because early on testing was a little bit scarce.
Sure.
But we started that process at the beginning of May. And when I told the managed care organizations that I was going to do this, they thought, because it didn't fall in line with what they call home and community-based settings rules, they thought that I was, I don't know, they thought I was crazy. Let's just put it like that. And I just said, well, listen, we're in a pandemic. Y'all don't know what's going to happen. I don't know what's going to happen. And I think this is the best path forward. Within 4 weeks, TennCare, which is a Medicaid in Tennessee, put out a memo that said best practices. And they listed that as one of the best practices for our program. And I look back at that period and I think to myself, maybe it's not a top down to solve this problem. Maybe it really is a bottom up. Like the people who know what it will take to improve the dynamics. I know that there is that everyone wants to kind of shy away from giving too many people at the ground level too much power to make decisions. But at some point, I think we really should do more listening instead of policy implementation and at the higher level, and then have it trickle down to the lower level.
Yeah, first of all, I love that. I heard or read about a few other examples similar to yours of this kind of living on site. And I think there was even one written up in the New York Times very much during that same period of setting up trailers. And I thought that was incredibly innovative and exactly what was needed, sort of that outside the box thinking. And I think you're exactly right about sort of this bottom up versus top down. What I meant earlier about centralized idea, these were about resources, like asking your company or others to go out and find PPE and compete with others, and that was such a crazy time that made absolutely no sense to me. Let's we want everyone using high quality PPE. Let's produce it, or let's do that. Yet let's also not try to police this. Let's let the best ideas come up. And if that means having folks staying on site, if that, there are all sorts of ideas. We heard of places having kind of wings, or one building was a COVID building, and places tried some very innovative things. I was involved here in Massachusetts in an effort to try to find some COVID only specialized facilities, and helping sort of as a relief valve for some of the hospitals. And there was some really outside the box thinking that was kind of coming from the providers and others in that community. And I know that was a really important part, and some of the best ideas I think that came out, because as I said earlier, I've been highly critical of the federal COVID response in a lot of ways. There's some nice examples like the vaccine rollout, but there are a lot of counter examples too where I think mistakes were made.
It's interesting because Brad Smith, who was technology and innovation coordinator for CMS at the time, he's from Tennessee,
right?
And I've met him a few times.
Sure.
And I remember reaching out to him and offering that as a suggestion for reducing the spread of nursing homes. And the reason that I bring this question up is because it ties into what I'm about to ask next. Here's community providers. Here's nursing homes. Here's hospitals. Why are hospitals the ones that receive the most funding and attention versus nursing homes? And how are we all going to, sort of rising tide lift all boats? How are we all going to come up together to improve quality of care if we can't value the nursing home industry and the community-based provider industry?
Long-term care broadly. We said earlier, the U.S. being this outlier, we spend more than any other country in the world on healthcare. I like to say we spend too much and we also spend it on the wrong things. And that's exactly your point. If you look at a country, once again, like the Netherlands, they spend a lot less than we do on healthcare, on hospitals, on physician services, but they spend a lot more than we do as a share of their GDP, gross domestic product. Every dollar spent in that country, they spend about twice what we do on long-term care. And guess what? It shows. Prior to the pandemic, I visited Rotterdam, toured a nursing home, saw everything that was going on there. Their nursing homes are much better staffed. Their staff are much better trained. They have a lot more community options. They have smaller home models. It's really powerful what investment and spending can do. And I think that really came through during the pandemic, where people kept asking me, why can't nursing homes just respond like hospitals? And I said, have you ever been in a nursing home? I know you've been in a hospital. We've all been in a hospital, but like, it's just it's not this high margin provider. They largely do Medicaid. I'm not trying to criticize anybody, but you've been in nursing homes around this space for a long time.
Yep.
It's a lot about putting out fires versus trying. And this was the ultimate fire, yet they didn't have the resources to really address it.
Yeah, this was like Pompeii.
Yeah, no kidding. I called it in one of my papers a perfect storm, because it one, it was COVID and everything that brought, but hitting this sector that just didn't have the resources to really respond to it. It couldn't have worked out any worse in a lot of buildings. And there was a building we ultimately wrote this up for a journal, but we had a place here in Massachusetts where we were looking at it for maybe being a COVID specialized facility. So we first wanted to test all the residents to see if anyone had COVID. So this is the beginning of April of 2020. Go in, test every resident. It turns out about 2/3 of the residents had COVID, all asymptomatic. Well, you can imagine what happens. Over the next 3 weeks, we tracked this. About 30 residents died. About half of the staff ended up getting COVID. It was just this that's the kind of speed we were talking about, where we went from, testing at the beginning of the month to over 24 fatalities by 2 weeks later.
Terrible.
It was terrible. And it was just that kind of, it was very fast moving. And there was nursing homes did not have the same resources as hospitals to really address this. And I think it comes back to, what do we value? And people ask me a lot was this ageism? And yes, there was some ageism involved, but also probably, some sexism and racism about our caregivers, who are largely women, many minorities, immigrants. And so it's really unfortunate that we haven't made this investment. And one of my hopes coming out of the pandemic is that we've learned something, but we'll see if that happens.
Have we learned something, Dr. Grabowski?
At one point, I was very positive that there was so much attention on nursing homes, and there was so much discussion and national panels. And as I'm looking at it today, I do think there'll be some small changes around the edges, but I'm not optimistic we'll see the kind of big transformational changes that you and I would both like to see.
So I'm a millennial, and I say this on almost every single show. I believe technology can solve all of our problems. Call me naive, but I really do. So on that note, do you think that there is a component or something that technology can attribute to the long-term care industry to help lower the necessity for the human element in the care process and incorporating some type of technological solution like remote supports, sensors, cameras, etc., without infringing on people's rights and independence?
Yeah, I think there's a real role for increased technology. I don't believe that, like, in Japan right now, they're exploring the use of robots as caregivers. I don't know that we're going to get there in the short term. We might have to get there someday, but I'm not holding my breath on that one.
Right.
But I do think there's other ways in which we can leverage technology. And one of the ways I really like, we've been talking a lot about just the long-term care, but guess what? Everybody who's living in a nursing home or living in their home, they don't just need lots of long-term care services. They also have a lot of medical complexity and chronic illness, and they need a lot of physician and clinician time. And having telemedicine, having that connection is super important. I think, there was a colleague that wrote a piece about physicians in nursing homes, and he called it missing in action. And they're just not there in the numbers that they need to be. Telemedicine can help address that. I did a project here in Massachusetts where we actually did a randomized trial of off-hour telemedicine coverage. So if Mrs. Jones has a medical event on a Wednesday night at 8 p.m., rather than calling her physician, who's likely telling the nurse, I don't know what to do, send her to the, down to the hospital. Sure. The ambulance takes her to the hospital. She's probably getting admitted and having an inpatient stay and thousands of dollars of spending for Medicare. What if she's looking just like I'm looking at you right now? She's looking at a physician, and that physician has a lot of peripherals where that physician can take her blood pressure or listen to her heart. And we found this actually prevented hospital transfers and saved the Medicare program a fair amount of money. The problem right now, and it goes back to our earlier point about sort of fragmentation, the program was quite successful in that it saved money. It just had the wrong pocket problem. It saved Medicare money. The nursing home had to pay for the intervention. So we'll see in the future if we can get the right pocket where the savings go to the person investing in this. And if you wanted to do this in one of your buildings, would you be saving money for your communities and generating some savings, or would you be saving the Medicare program? And there may be other reasons to do this as part of if the residents are willing to pay for it, if it can help with attracting people. But at the end of the day, there has to be a return on investment.
There is this ideology, I could say, in the long-term care space where a lot of the ways that people improve their overall well-being is if they can have more community integration. If they can leave, whether it's their facility or even their home for that matter, and they spend more time in their community. I mean, I don't know how long you spend in your home every single day, but I venture to say that you probably leave it at some point every single day.
I tried
during the day, right? Yeah, exactly. So imagine if you stayed in your house for a week or even longer for that matter, and had all these services coming to you, whether it's in a facility or in your own home. A lot of times, because we are so compliance driven, a lot of our we supplant this community integration with doctor's appointments and doctor's visits. And so we have these robust transportation divisions that are just strictly around let's go, we'll pick up your groceries and we'll take you to the doctor. And, we'll call that community integration. And occasionally we'll plan this big group trip and we'll all go to the park, right? And I would think that if you could find other technological solutions like telemedicine to remove the necessity for having to go to those PCP appointments all the time and having to make those ER visits on occasion, you could actually use the transportation divisions for community integration to get them out of the home, and to really engage with the community that they live in, that they love, that they grew up in.
Yeah, I love it. Let's actually improve their quality of life versus let them do the things that they love doing.
Yeah, I do believe that there is room. It's not going to solve all the problems, but I do believe that there is room for remote supports to just replace the necessity for, specifically with people with cognitive disabilities that don't need to be in a nursing home, probably live in their own home. And there's only certain hours of the day that are cause for concern, or certain conditions that occur that could create a concern. And imagine having a ADT for people that are elderly and physically disabled. And so instead of having this 1-to-1 care ratio between a caregiver and an individual receiving services, you could have a 4-to-1. And that would technically draw down the cost of care because you're splitting that fee instead of it being, paying one person to take care of another, you're actually paying one person to take care of four. And so the fee for that individual to compensate that one person would be split 4 ways. Now, we're nowhere close to this being scalable, but We are starting a pilot with United Healthcare, and I'm optimistic about the outcomes. But again, going back to how we talked about earlier, only out-of-the-box thinking, I believe, is going to solve our issues with long-term care.
I totally agree. And we got to try, put a lot of shots on goal and see what actually gets by. We
Hockey
try
reference. I love it.
we tried a sort of a pilot program with a big home care company. You're trying a checklist, and I think these are really challenging. But each time a caregiver would end his or her shift, they would answer a set of questions. How is Mrs. Smith doing, and does she seem different and short of breath, and sort of these very quick, adding maybe 30 seconds to a minute as she's kind of he or she is clocking out the caregiver. They're answering a series of questions, and did really well in the pilot. We didn't, when we actually extended it out, unfortunately, it's really hard for a lot of home care companies to do anything with that information. So it's being collected. But what do I do if you tell me Mrs. Smith has a changing condition? Do I have the wherewithal? But as we get greater integration in that home care company, it potentially is integrated with medical services, then we're now we're cooking. It's sort of all right. Yeah. Then we can actually do something with that information. So I love trying these different ideas and seeing what works.
So we always like to end the show with a call to action.
Right.
What resources would you recommend for our listeners to learn more about healthcare policy, long-term care, and elder care planning? Are there any upcoming changes or policies they should be keeping an eye on? Yeah,
for sort of tracking all of this, I think there's so much great kind of national reporting on this issue through the New York Times, the Washington Post, the Wall Street Journal. There's just a great set of reporters and writers that really track this closely, and not just those publications, but many others here in Boston, the Boston Globe, and I'm sure Tennessee has. So the reporting on healthcare has never been better, and I think following that it is super important. In terms of big changes for long-term care, I want to highlight two that I'd love everyone to track and weigh in on. And one of the things I like to say is this isn't going to change unless we change it, because all too often long-term care isn't a part of our agenda. You asked me very bluntly, are things going to change? And I would like to tell you yes, but if I'm being honest, I think I don't think we're going to see major change. We're only going to see major change if our politicians view this issue as important. And long-term care never comes up in debates, at the Senate level, the presidential debates, or, you just don't hear it a lot in from governors. And it's not front and center. And recently, Biden has had to bring it up in some State of the Union addresses. I think it's getting more attention. And so I think that's a really positive sign. And all of us continuing to hold our politicians to providing more resources and attention here, I think is really important. And the two changes I'd like to highlight: one, the Biden administration is looking at minimum staffing standards for nursing homes. I said earlier, it's all about staffing. We're going to hear over the next month or so what those standards are going to look like. I know for providers, this is going to be very challenging, and how we pay for this is going to be kind of an interesting part of all of this. But I really think, I said earlier, staffing is the most important component towards good quality. This is really a huge step forward. The second step just came out last week. The Biden administration announced kind of increased support for family caregivers. And we've talked a lot about sort of the formal long-term care sector. There's always going to be a role for family, even in Washington State, with all of their huge advances and great policy work. Families matter. They matter in the Netherlands. They matter in Washington State. They matter all over our country, and they always will. And how can we best support individuals? Because the burden here largely falls on women. Lots of them have to leave the workforce. High rates of depression, physical issues with caregiving. How can we give them the support that's needed. And so I love that we're trying to both support our older adults in nursing homes, but also support a lot of those caregivers in the community, which then supports the individuals who need this care in the community.